Over the course of this video and the two subsequent videos, we will be covering disorders related to blood, or more specifically blood cells. That includes white and red blood cells plus lymph and coagulation products. Can you think of the one thing these cells all have in common? If you said they all started out in the same place, you would be correct. And if you said that they all came from the same cell type, you would also be correct. So a disorder that might be a disorder of white blood cells can also impact red blood cells, platelets, and potentially T and B cells. Because of this commonality that the various blood cells have, we may mention some aspect of a disorder, that is of the red blood cells, when discussing disorders of the white blood cells. But we aren't going to go into that topic in much depth until possibly a later section. We are first going to cover disorders of the white blood cells. And the primary purpose of white blood cells is to fight infection. While they originate in bone marrow and circulate via the blood and vessels and lymph, they are a part of the immune system in that they play a role in fighting off infections, but play no role in coagulation. The lymphatic system is a network of tissues and organs that help to rid the body of toxins, waste, and other unwanted materials. The primary function of the lymphatic system is to transport lymph, a fluid containing infection-fighting white blood cells, throughout the body. Now this diagram it demonstrates the developmental process of each of the blood cells and what they go through in the maturation process. At the top, so up here, where we start out with the 0 points stem cell, these are where the cells are at their most immature, or not as differentiated as those down here at the bottom. The cells at the top are immature or not as differentiated as those at the bottoms, but they are essentially going to become those mature cells. But at this stage up here, they can't carry out those functions yet of whatever they're eventually going to once they grow up. But with each of these steps of the maturation process, they move closer to being fully functional adult cells. As you can see in this chart, fairly quickly in the developmental process, the lymphoid stem cells, right here, will migrate to the lymphoid tissues, and that is where they will mature, while the myeloid stem cells stay in the bone marrow. So if a disorder affects this developmental process early on, cells may not mature or play their part in bodily functions. As we discuss the various blood and lymphoid disorders, it might be a good idea to keep this diagram handy. I have found it very helpful to keeping everything straight. You can find this diagram on page 241 of your textbook, or it's been placed in the study guide. Now we're going to cover or talk a little bit about non-neoplastic disorders of white blood cells. One note I want to make here is that frequently white blood cells are abbreviated to WBCs. So throughout this material, you will see and hear the letters WBCs used. Just realize it means white blood cells. Now, the white blood cell disorders that are covered in this presentation are related to the blood cells themselves and not any infectious process. Now, of course, we have to have one exception, which is infectious mononucleosis. This is an infection, but we're discussing it here with the non-neoplastic WBC disorders because of how it affects white blood cells development. The role that white blood cells and lymph cells play in infections, inflammation, immunity will be discussed in subsequent modules and subsequent weeks. Okay. Normal white blood cell count is 4,500 to 10,500 cells per microliter. A deficiency of white blood cells is called a leukopenia. And this is when the WBC count drops below 4,500. So then the opposite is when the WBCs rise above 10,500. And this is called a leukocytosis. Leukocytosis is usually seen in response to infections and invading organisms. So we'll talk a little bit more about leukocytosis when we talk about inflammation and immune issues. Leukopenia and leukocytosis can be normal responses to different stressors, such as invading organisms. When it becomes abnormal is the further white blood cell count drops or rises and the longer these abnormal levels continue. So if there's an elevation of the WBC count and that persists in absence of any infectious organism, then that is considered pathological and is an abnormal white blood cell disorder. So, some of the disorders we're going to cover are neutropenia. Now, neutropenia is when the neutrophil count drops below 1,500. This means the cells and tissues are beginning to have a compromised immune response. Agranulocytosis is a virtual absence of neutrophils. And neutrophils, if you remember back to the chart, are a mature cell, a mature white blood cell that plays a role in fighting off infections. So, when you have that drop of, the neutrophils, this is an indication of an impaired immune system. And agranulocytosis means that the neutrophil level is dropped to less than 100 cells per microliter. And at this point, the patient's immune system is severely compromised, and an individual with this low of a neutrophil count may not be able to mount an immune response of much worth. Infectious mononucleosis is a viral infection that results in leukocytosis, or an elevated white blood cell count. The key to why this is a disorder of the WBCs is because the B lymphocytes have receptors for the Epstein-Barr virus. And once the person that is infected with the Epstein-Barr virus, their white blood cells will carry, or more specifically the B lymphocytes, will carry that portion, or a portion of the virus becomes a part of their genetic makeup, so to speak, of that, or the genetic makeup of the B lymphocyte cells. Aplastic anemia is a disorder that affects the stem cells, resulting in reduction of all subsequent blood cells. This disorder will be discussed more with disorders of red blood cells, but is mentioned here because it can cause a decrease in the number of white blood cells and neutrophils. Now, let's get a little bit more into neutropenia. Now, as I mentioned before, neutropenia is when the neutrophils drop below 1,500. This means that neutrophils have continued to drop and are at levels where patients are developing a greater risk for infection. There are two categories of neutropenia. The first is called acquired, simply because these are disorders that the patient develops over time. Now, it can result from multiple different disorders, but what happens is there is a suppression of bone marrow stem cells, which leads to decreased production of all blood cell types. Neoplastic disorders originating in the bone marrow can result in decreased neutrophil production. The second category of neutropenia is congenital neutropenia, and as the name suggests, there is a genetic component to this disorder. There are two predominant types of congenital neutropenia. The first is a periodic or cycloneutropenia, which is an autosomal dominant disorder. This disorder is characterized by periods of neutropenia, which develops every 21 days and lasts approximately for 2 to 3 days before neutrophil counts return to normal. The second is severe congenital neutropenia, or Costman syndrome, which is an autosomal recessive disorder. The key difference, besides one being an autosomal dominant disorder and the Costman or congenital neutropenia being an autosomal recessive disorder, is that with congenital neutropenia, we don't have this cyclic pattern that we see with periodic neutropenia. The manifestations, the clinical manifestations for these disorders include fever and chills, which are normal signs of infection. An exception may be is if the patient has developed severe neutropenia. Patients are said to have severe neutropenia when their neutrophil counts have dropped below 250. At this point, the patient may not exhibit a fever in the presence of an infection. Other manifestations in a patient with neutropenia include ulceration in the skin and gastrointestinal tract. These are areas where the neutrophil is present and helps support these barriers as the first line of defense against invading organisms. The respiratory tract is another site where infections can progress faster and become fatal a lot quicker. What are characteristics of bacterial infections that may be missing in the neutropenic patient is pus. We normally think that if there's an infection or a break in these epithelial barriers, the skin, the respiratory GI tract, we frequently think of infections that have gained entry to the body in these areas, in these breaks. One of the things we frequently see is fluid discharge, and if it becomes pussy looking or that it's not clear anymore, because of the impaired levels of the neutrophils, the white blood cells, we may not see this response. Preventing infections in the patient who is neutropenic is key. The best way this can be done or accomplished, especially by healthcare workers, is through vigilant hand washing. When coming into contact with patients, it is essential to wash your hands before and after patient contact. This is true with any patient, but is especially true with the neutropenic patient. Now I briefly mentioned infectious mononucleosis. The cause of this disorder, this viral infection, where patients or individuals come into contact with saliva containing the Epstein-Barr virus, EBV. The Epstein-Barr virus is especially effective in that it is successful in infecting 90% of the individuals exposed to it. The B lymphocytes, as I mentioned previously, has a receptor on them that is especially for the Epstein-Barr virus. When the virus attaches to the B lymphocytes, it incorporates itself into that lymphocyte's genome. Because of this, the virus is present in the individual for life. The individual's immune system may kill off the majority of the Epstein-Barr virus, but there will always be cells that carry this genetic material. This is a key piece of information to keep in mind as we move forward in our discussions of other disorders of white blood cells in lymphoid tissues. And actually beyond this. This is going to come up again. In the progression of this disorders, we see a periodic shedding of parts of the virus. These parts of the Epstein-Barr virus can be found in saliva. This is why the initial site of infection is the oral cavity and why kissing provides the close contact needed for transmission from one host to another. Signs and symptoms include malaise or being tired, which is frequently the only sign a patient may exhibit for a significant period of time. The other symptoms you can see here on the slide are the anorexia, chills, pharyngitis, because the pharynx is right there in the mouth, in the oral area, fevers, headaches, lymphadenopathy, hepatosplenomegaly. These are all results of the body's response to this virus. This includes an elevated white blood cell count over 12,000. The majority of individuals who contract this virus and resulting disorder usually recover without major life-threatening consequences. This slide simply emphasizes the key point that while the patient's immune system may kill off most of the Epstein-Barr virus, there may still be components of that virus on some of the cell's genome. So it presents you with a nice summary of this. Now we're going to go on and talk about some of the, shall we say, the actual disorders. And unfortunately, the etiology or what causes the development of these neoplastic disorders is still kind of a big unknown. With many disorders affecting other cells or body systems, we can say if A happens, then B will occur. With most neoplastic disorders, we can't say that. We can't say there's one triggering event with any certainty. We can say, we think if a person smokes, they have a really big chance at developing lung cancer. But we've never been able to scientifically say with 100% assurity that that will happen. The first disorder, neoplastic disorders, we're going to talk about are the leukemias. The key point to remember about leukemia is that the cells don't want to grow up. So if you remember back to that chart that talks about the developmental stages of blood cells, we had mature stages, and then we had the immature phases. Leukemias are those immature, are going to you're going to be seeing the changes and the lack of development in these cells. Something at different steps in the process happens, and then the cell changes and stop maturing. Leukemia can be categorized into acute and chronic. Now, it can actually be a lot more complex process, and the World Health Organization has developed a system that starts with classifying leukemia according to onset. This means there was a sudden onset of symptoms, or was it a slower process? Acute leukemias usually have a sudden and stormy onset of symptoms, so their symptoms are going to be a little bit more severe. While chronic leukemias have a slower onset, meaning individuals may have had leukemia for a while before they even know it. The next step in classifying leukemia is identifying if the cell changes took place in lymphocytic or myeloid precursor cells. With all of these leukemias, there is a genetic change that has taken place, leading to a change or an inhibition of the cell's ability to mature. The unknown factor is the trigger that caused this mutation. Common symptoms with the various forms of leukemia can include fatigue resulting from anemia, low-grade fevers, night sweats, weight loss due to the rapid proliferation and hypermetabolism of leukemic cells. There may be bleeding due to decreased platelet counts, bone pain and tenderness due to bone marrow expansion. So as you read through this slide, all these symptoms result from the changes that are taking place because of the changes to the blood cells. Infections can result from neutropenia, with the risk of infections rising steeply as that neutrophil count drops below 500. Generalized lymphadenopathy, splenomegaly, hepatomegaly are caused by infiltration of leukemic cells, but are more common in acute lymphocytic leukemia. So we're going to go through each of the leukemias, and when we talk about clinical manifestations of leukemia, they're kind of a common core group that we've talked about here. And if there is anything specific to that type of leukemia, I'll mention it with that leukemia. The first leukemia we're going to talk about is acute lymphocytic leukemia, ALL. 90% of ALL patients have structural changes at the chromosomal level, leading to changes in the cell developmental process. The changes occur to the precursor B or T lymphocytes called lymphoblast. As the image indicates, the cells have moved outside of the bone marrow to the lymph system, meaning changes will only affect the lymph cells. One possible trigger to these cell changes is ionizing radiation. This is the most common form of childhood cancer. It accounts for 3 of 4 cases of childhood cancers. Leukemias in general are seen amongst individuals who already have one genetic abnormality. An example would be the high incidence of leukemia in people with Down syndrome. The onset of symptoms can be very sudden and profound, hence acute. The symptoms can result from the overwhelming proliferation of immature lymphoblast cells and the need to store them somewhere. This is why the symptoms for ALL are associated with lymph nodes and organs associated with the lymphatic system, such as the spleen. Involvement of the CNS or the central nervous system is more common with ALL because the cancer cells can cross the blood-brain barrier. These symptoms can include headache and seizures and comas. Now, acute myelolytic leukemia. The AMLs are a diverse group of neoplasms that affect the myeloid stem cells in the bone marrow. Since it is the stem cell where the issue arises for AML, acute myelolytic leukemia, changes can affect all myeloid cells. The overgrowth, and that is the key thing that I may not have mentioned with ALL. What happens is these disorders occur in these immature cells, and the things that normally keep the replication and proliferation process of cells in check and in that organized process, remember, we've kind of mentioned this before when talking about other disorders, is that with the cancerous or the neoplastic disorders, that control kind of goes out the window. The cell cycle, where it has those checkpoints, where cell replication checks for, like if there's been damage done to the DNA of the cells, those checkpoints, sometimes something happens and altered DNA or an alteration in the genetic material has occurred, and those checkpoints let that through, and then neoplastic cells want to just keep growing and growing and multiplying, and it's a very disorganized, out of control process. So with these stem cells, there's an overgrowth that occurs with these cells, and it leads to suppression of other progenitor cells, causing disorders such as anemias, neutropenia, thrombocytopenia. An increased risk has been seen in patients who have been exposed to formaldehyde and benzene, and these are common substances found in cigarettes and gasoline. The most common population affected by this group of leukemias are young adults, those who are 20 to 40 years old. Because AML involves an overgrowth of myeloid progenitor cells, these cells accumulate initially in the bone marrow and can lead to overcrowding in the bone marrow. This overcrowding can lead to swollen and painful joints because that's where bone marrow is. Other symptoms are more commonly associated with forms of AML are changes to skin, gums, and soft tissues as they are invaded by these malignancies. Now, chronic lymphocytic leukemia, or CLL, is a disease of immature, immuno-incompetent, minimally self-renewing B cells, which develop faulty apoptotic mechanism. This means the cell doesn't know how to mature or shut itself off like normal cells do. With this disorder, there are the usual thoughts about what happened to cause the inability to mature or shut off, but nothing definitive has been established. This is the only category of leukemia that has a noted familial link. If one family member has it, there is an increased probability that another family may develop CLL. CLL does not demonstrate sibling and parental patterns that would indicate it is an inherited disorder. This is a disorder that is rarely seen in anyone under 40 years old, and the peak onset of symptoms is around 72 years of age. It has the possibility for the most favorable outcomes of leukemias. This is related to the fact that it is a disorder that has two paths it can follow. One is a slow progression. Patients are frequently asymptomatic at the time of diagnosis. The prognosis for slow developing CLL is that they are more likely to age and die from something else before they die from this disorder. Unfortunately, there is a more rapid version of CLL where symptoms do not start until adulthood, but when the changes in symptoms start, they are of a noticeable intensity and unpleasantness. The patient will experience a quicker decline or progression with the disorder. With the rapid progression, there is a noticeable onset of lymphadenopathy and hepatomegaly. Chronic myocytic leukemia, say that one rapidly, CML, affects the pluripotent hematopoietic progenitor cell. So that means that very initial progenitor or stem cell is where this is occurring. It is characterized by merogranulocytes, erythroid precursors, and megakaryocytes. We know a little bit more about the specific genetic changes that occur with this disorder. It possesses a chromosomal abnormality that allows the cell to bypass signals that control growth and differentiation. While the cells have matured a little bit further than AML, the cells are still immature. This is also a disease of older adults with the peak occurrence at 67 years old. CML has a unique progression of the disease in that there are three distinct stages that the disease progresses through. The chronic phase has a slow onset of typical leukemia symptoms. This phase can last up to 14 years. The accelerated phase can display the same symptoms as the chronic phase in that the patient will still have splenomegaly or hepatomegaly, increased basophil counts, but all have increased or worsened. We start to see bruising and bleeding at this stage, and this stage can last 6 to 12 months. The terminal phase is as bad as the name sounds. The stage is characterized by worsening of symptoms. They have blast counts of over 100,000. The median length of survival is 3 months. Now we're going to talk about non-Hodgkin's or non-Hodgkin lymphoma. It was previously called non-Hodgkin's lymphoma. But this is a more common form of cancer and accounts for 4% of all cancers worldwide. This is a cancer that usually starts in the lymph nodes and can be spread to other lymph nodes or other tissues. This disease involves the malignant transformation of either T cells or B cells during their differentiation in the lymphoid tissues. The greatest portion of changes are occurring within the B cells. 80% of cases involve the B cells. 95% of cases occurs in adults, with half of those being over 65 years of age. So this is primarily a disease of the adult. There are over 40 different types of non-Hodgkin lymphoma. The most frequent kind are the mature B-cell non-Hodgkin lymphomas. Follicular is a form of non-Hodgkin lymphoma that accounts for 1/3 of all NHL cases, or non-Hodgkin's lymphoma cases. The peak instance occurs around 60 years of age. The primary site is lymph nodes, but other sites can include bone marrow, peripheral blood, head and neck region, gastrointestinal tract, or the skin. It has a slow growing course with a median survival rate of 6 to 10 years. 1/3 of all cases can transform into a diffuse large B-cell lymphoma. Diffuse large B-cell lymphomas, the prevalence of diffuse large cell B lymphomas is greatest between 60 and 70 years of age. And like all neoplasms, the cause is not fully understood. But with this type of lymphoma, many involve having had the Epstein-Barr virus or HIV infections. This is a rapidly evolving malignancy, and if untreated, it can be fatal. With intensive chemotherapy, complete remission is achieved in at least 60% of the time, with 40% or sometimes greater than that remaining disease-free after several years. Burkitt lymphoma is a form of non-Hodgkin lymphoma that is seen greatest in Central Africa, where there is a significant rate of the Epstein-Barr virus infections, and malaria are common. The peak age of occurrence is 3 to 7 years old. 100% of patients in Africa have had an infection where Epstein-Barr virus was the cause of that infection. So there's a strong link between Epstein-Barr virus and this form of lymphoma, Burkitt lymphoma. The primary manifestations involve the jaw and facial bones, but this form of cancer is very responsive to aggressive chemotherapy with a cure rate of 90%. Mantle cell non-Hodgkin lymphoma comprises less than 10% of all NHLs. It primarily affects older persons, with the average age being 60 years old. It has a rapid rate of progression, and only 1 in 5 patients survive 5 years. Marginal zone lymphoma, non-Hodgkin lymphoma, affects the lymph cells that are probably the most mature, but these lymph cells are going to reside at the very edges of the lymph nodes, meaning they aren't going to spread quickly. They're well localized. So we commonly see these in the splenic marginal zone. The progression of the disease is usually a very slow course, and because it's very slow, and because these cells, the leukemic, the non-Hodgkin's lymphoma cells, don't spread real rapidly, this form of lymphoma, the marginal zone, is successfully treated with chemotherapy and radiation. How lymphoma, non-Hodgkin lymphoma, manifests itself is dependent upon the type of lymphoma, if it's slow progression or aggressive, and the stage of the disease. Now we're going to talk about Hodgkin's lymphoma. And if anyone is familiar with the Kansas City Chiefs, you've probably heard about Eric Berry, who was diagnosed, treated, and successfully cured of this form of lymphoma a couple of years ago. And as with all forms of neoplasms, little is known about what causes the changes that lead to this disorder. While a direct connection can't be met, it appears that persons with a history of having had infectious mononucleosis, here we're coming up referring to our old friend, the Epstein-Barr virus again. We know that people having infectious mononucleosis are at increased risk for the development of Hodgkin lymphoma. This disorder has a couple of unique traits that make it a little easier to identify. First, Hodgkin's lymphoma will develop in a single lymph node and spreads contiguously. This means it will only spread to a lymph node directly in line with it. You won't see the pattern. You'll have a lymph node affected, say lymph node A, and it will spread to lymph node B, lymph node C, and then lymph node D. It's not going to spread from lymph node A to lymph node D. Malignant cells will not spread from a lymph node in the neck to one in the legs until it spreads to each lymph node in between. The second characteristic is the presence of an abnormal cell called a Reed-Sternberg cell. These are unique, large, atypical mononuclear tumor cells. These cells release factors that induce the accumulation of reactive lymphocytes, macrophages, and granulocyte, which make up 90% of the tumor cells. Now, there are two types of Hodgkin's lymphoma. There is nodular lymphocyte predominant Hodgkin lymphoma. Hopefully you're noticing how we can sometimes not avoid using really big long names for the disorders. Sorry about that. But it represents only a small portion of Hodgkin's lymphoma. It is a form that exhibits nodular growth, but is rare that it will not contain Reed-Sternberg cells. And this form of Hodgkin's lymphoma exhibits a slow progression and has an 80% overall survival rate. Classic Hodgkin lymphoma is characterized by mononuclear Hodgkin cells, and it will have the Reed-Sternberg cells. Hodgkin's lymphoma occurs most frequently in two different time frames in an individual's life. The first is in early adulthood from 50 to 40 years of age, and older adulthood over 55 years of age. The last disorder we're going to talk about is multiple myeloma. This is a B-cell malignancy of terminally differentiated plasma cells. 1% of all cancer, it comprises 1% of all cancers in Western countries. It's higher in men and people of African American descent. It occurs more frequently in the elderly. The peak onset is 63 to 70 years of age. We're going to see a proliferation of malignant cells in the bone marrow. You're going to see osteolytic or bone lesions throughout the skeletal system. And this is an unregulated production of abnormal monoclonal paraprotein referred to as the M protein. Plasma cells only produce the light change of the immunoglobulin molecule. Because they're lightweight, the change are easily excreted in the kidneys, and this leads to kidney failure. The light chains are toxic to renal tubular structures. The best way to describe the manifestations of multiple myeloma are listed in this picture. Osteolytic, I mentioned the osteolytic bone lesions. So they're going to have a lot of bone pain. And there's going to be hypercalcemia because the bone is breaking down. You'll see pathological fractures. Plasma cell secretion of the paraproteins. You're going to see hyperviscosity of body fluids. We mentioned this, how this can affect the kidneys, but it also can affect the heart. So the renal failure, you're going to see more protein in the urine. You might see anemia and neutropenia. This can be a very uncomfortable disease.